Welcome, everybody. It's so great to see everyone this afternoon for our AAST WITS webinar. Today, we are going to be talking in the fast lane, a discussion about ACS staffing. And so we have three great speakers who are going to help discuss this. First and foremost, not foremost, of course, we're all equals here, but first will be Kristen Stoudemire. She's a trauma and acute care surgeon at Stanford, and she also serves as the associate chief of the section of acute care surgery and holds the Betty and Gordon Moore Endowed Faculty Scholar position. So Dr. Stoudemire has also spent some time looking at staffing models, and she's going to give us her insights and a little bit of an overview of really what's out there and help educate us. And then we're going to have a few different, two different perspectives after that. So Dr. Kim Davis, who is professor in chief of acute care surgery at Yale, and one of our WITS founders, is going to discuss with us what it's like to try and recruit people into your system and some of the challenges associated with that. And then our third speaker is Michelle Fiorentino, and she is a trauma surgeon at Christiana Care and is a newer faculty member. And so she is going to talk to us about what it was like to seek out a job and what her expectations were and really what she was looking for. So trying to look at things globally and then from the perspective of a recruiter and a recruitee and kind of build the discussion from there. So we look forward to the comments from our panelists and then also your questions and comments after that. So with no more ado, we will start with Kristen.
Great, thank you. And it's great to see everybody here and great to see some familiar faces as well. I'm going to be just pulling up a PowerPoint here, mainly just to kind of set the stage for the discussion, I think. I think there's a lot of stuff that we're all familiar with. And so I really took a step back and said, well, how can we paint a broad picture for the purposes of having a discussion around workforce issues such as hiring and taking a new job. So one thing which at least we are doing in the Economics Committee a fair amount is to really try to broadcast how the ACS model of care and ACS surgeons have improved care for patients requiring emergent interventions. And we've been able to show that. And there are advancements in patient outcomes. We've improved resource optimization and also really advanced knowledge of advanced surgical conditions. But on the other side, as we've been doing all of this, there have been challenges. We have taken on a lot of very complex patients, high volumes of patients, and oftentimes many places have staffing shortages. And there's a concentration of night call now that's happening for the ACS model, and less so now for the other general surgery specialties, which is very relevant when you're considering trainees and what specialties they might want to go into. Kind of what really kicked off this discussion in earnest is a paper presented at 2021 AAST by Pat Murphy and Mark DeMoya. And they did a relatively limited survey, but it still mainly stands in importance because it's the only survey and because it really kicked off this discussion. And what they found is after querying 483 division chiefs, 68 of which responded, that the median number of weeks that most people were on service was approximately 26 weeks. And the median number of 8 12-hour call shifts, the median number of call shifts was approximately 8. So this was the starting point for discussion. Also, just so this kind of work stays on your radar, Jamie Coleman has been very active at looking at the physiologic impact of call and the type of work that we do. And this is also very important considering setting the stage of how do we want to be shaping our workforce and our workloads going forward. And importantly, what she was showing in this study is that, not surprisingly, when you're not on call, we're not getting the required amount of sleep. That's not too surprising. But as you go from being on call at home and not called all the way over to being in-house call, the amount of sleep you get decreases. And what they also find is that the indices for being rested or feeling rested and burnout also change as you go from not on call over to in-house call. Now, this has real impact, not just on us, but our patients. So this is relevant. This is a relatively old study, and actually Dr. Davis and I are doing a study with the same lead author in this paper, looking at it specifically acute care surgeons and burnout. But what Tate and his group showed is that of the surgeons that had made major medical errors, for one, they blamed themselves. They attributed this to individual rather than system level factors. But also importantly, that errors were related to quality of life, depression, and burnout pretty strongly. So this paper was pretty important and circulated, I think, less in our societies than in maybe some others. But I think it also speaks to how we have to be very deliberate about how we continue to evolve our workforce. So if we think about models for ACS services, you'll hear people say things like, well, if you've seen one ACS model, you've seen one ACS model. But there really are patterns that start to shake out as you look across academic ACS models. Keep in mind, of course, I'm really confining this discussion to academic ACS models because once you go outside of academia in the private world, there's a variety of different configurations. But if we look at academic ACS models, we have the traditional historic models where you basically divide the amount of work by the number of surgeons that you have, and that's how the work gets done. This usually is in smaller places or places where the acute care surgeons are the general surgeons for the hospital. What has been happening over time is a move towards what we're kind of putting in a giant bucket as time-delimited clinical work models. And the idea around this is that you define how many shifts, how much work really each person should be expected to do. And then you assign the work based on that. So there's this kind of this gradation that you can see as you look across different centers from a traditional model to time-delimited, sort of blended to traditional to time-delimited by sessions or shifts. And session is a term that's being used more nationally. When you consider there are pros and cons to these models, and they have evolved organically for a reason, and those reasons usually have to do with what the local conditions are and local needs are. And so there are some places that are hardcore traditional model, and they're like, we love it, we work a lot, but we are the big bad surgeons in the hospital, and we make a ton of money. And so where those are successful, it's a very different experience than where there are surgeons and shifts. But if you go to a place that's purely shift-based, and you talk with people who have a very clear shift-based structure, they say, oh, it's wonderful, we all love it, everyone's really happy, they can do their research when they want. And so there are definitely pros and cons to both of these. I'll say as well that, and Dr. Davis and I actually worked on a workforce paper that's going to be hopefully published soon that really goes into more detail about all these pros and cons of comparing these different types of models. Just for this last bit, I wanted to share this with you all because I thought this was very interesting. There was a presentation, it's now a little bit old, it's pre-COVID, or actually probably mid-COVID, 2020. The AAMC and Sullivan Cotter worked with VCU to do a survey, and this is not specific for ACS. This is specific to academic medical centers, looking at how work was broken down. They looked at those specialties that use sessions or shift, and they wanted to see how are centers using their workforce in terms of sessions or shifts. And if you look here at this pie chart, what you can see is that they clearly base this on a 40-hour work week because the biggest number is 10 4-hour shifts in a week. And most surprising to me was that it was actually the number of weekly sessions for 1.0 FTE was actually 9, so a 36-hour work week, which I can't even begin to comprehend. They also looked at, by different specialties, what were the median and average hours per shifts, how many shifts per year, and how many annual hours. And this, if you've spoken with colleagues in other specialties, really aligns with what I've been hearing about, which is, in general, about 14 to as high as 18 shifts per month for some of these other specialties. Out in the community centers that are not academic, it's a little bit higher than that, sometimes 15 to 19 shifts per month. But if you think about what we're doing, and if you extrapolate from Des Moines' work, basically we're well over all of those specialties, pretty close to anesthesia and a hospitalist. But we're definitely topping out compared to these other groups. Now, the reality is that this is the last slide I have because I don't want to type the discussion, but this is particularly relevant, even though this slide is old, this is particularly relevant to the challenges that we are facing today with all the changes in DC. So over time, our academic efforts were largely supported through academic funds coming from the NIH, with some cross-subsidization from the clinical enterprise. But what's happening now is that we're experiencing changes to some of that money flowing to our institutions from the academic side. And then our clinical side is getting squeezed too. And I think this is why this is important for people who are practicing acute care surgeons in academic centers, is that the result of the shift of this, the shift of funds is going to be, as we rely more and more on clinical funds, there's going to be more and more pressure on acute care surgeons to take on more clinical work. And so yet another reason why we have to be very deliberate about what we should be doing, how much we should be doing, and how, because these changes and these forces are only going to get stronger over time. So with that, I will stop my presentation so that we can go on to probably the meat of the discussion.
Fantastic. Thank you so much, Kristen. I feel like that last slide is sometimes how just my head feels getting squeezed into different compartments. Awesome. All right, Dr. Kim Davis, we look forward to your comments on what it's like to recruit somebody into your system and what that's your opinions on that, your thoughts on that.
Yeah, and I'm going to actually rely on Eileen, Lillian, and Charisse because they are all running large divisions. But I think that the slide that Kristen showed at the end really defines academic healthcare right now, and the problems that we're all facing with regard to how to distribute the wealth in a surgical or in a clinical practice model to make sure that you have enough primary care docs, enough pediatricians, enough radiologists, enough pathologists, et cetera. So a lot of the larger academic health centers are going to what we call a funds flow model. And what the funds flow model means is that the funds all go centrally, and then they get allocated out by who's ever in charge of funds allocation. And oftentimes the money that's coming in, which is generated predominantly by proceduralists, and we fall into the category of proceduralists for the most part, although we do have a really high component of E&M in what we do, so we're kind of not really pure proceduralists. But the money comes in from the proceduralists and then it's disseminated outward. So a lot of our colleagues are being forced to work in an RVU model where they have to generate 60% AAMC RVUs in order to get 50% average AAMC salary, or some alliance along those lines. I think what we as acute care surgeons need to think about is how we sell ourselves in the types of work models that Dr. Stoudemire described or Kristen described, so that we are acknowledged for showing up and doing our job rather than being RVU dependent, because most of us think of the front door of the hospital as the emergency room for the volume of and the transfer center for the volume of patients that we see. And we have to be, we're kind of like firemen and policemen, right? We have to be in the hospital 24/7, 365 to take care of the patient. You may have a really busy night when you're an RVU generator, and you may have a night when you actually get to sleep. Those are fewer and farther between. But, and then no RVUs come in. So a lot of acute care surgery programs are looking to being staffing models or shift-based models, whereby you get your salary as long as you show up and do the work. If you generate more money for the hospital by generating a lot of RVUs, they love you because they take your money and they distribute it to all the people that can't make any money. So that's kind of the backdrop of where I think most major institutions are coming from. I think a lot, and Eileen, Lillian, and Charisse can comment. We have bought into Mark DeMoya's staffing model. So although I will say that our hours are 2,500 hours a year for a full-time FTE, and I'm in the middle of discussions to dropping that down to 22 or 2,100 because it's too much. But I think that a lot of places are going to, you work 2 weeks a month and X number of calls a month, and the rest of your time is your academic or your research or your go to the dentist time. Caveats to that, though, are that you never know what's going to happen. And I will say that even though on paper I am fully staffed, I am not fully staffed. Because I have one military surgeon on deployment. I have one surgeon who is out on extended FMLA. And I had one person, actually 2 of us broke things recently. So that we don't have the depth and the ability to backfill, and people are picking up extra work to try to cover for the people who are on paper working but aren't actually physically in the hospital. So I think as you build a staffing model and you think about building staffing models, you have to build a little bit of redundancy into it. And that redundancy is a really hard sell, which I think which is why I think you really have to be very cognizant of how you set that number of hours per year or number of shifts or number of calls. I also think that there is a driving pressure, and then I'm going to shut up and let everybody else talk. I think there is a driving pressure to not have the trauma and emergency general surgeon be responsible for everything that happens in the intensive care units at night, because the vulnerability is that the patients that are going to get the primary attention of the operating surgeon are the patients who are getting operated upon, and that there is a vulnerability in coverage in the intensive care units at night. So as we look at staffing models, I think that what we are going to start to have to focus in on is how do you have 2 docs in-house, one of whom probably isn't going to generate any RVUs except maybe a central line or 2, maybe drop a critical care bill, but prevents the $40 million lawsuit down the road. So these are the types of arguments that those of us who are building divisions and healthcare systems are having with our hospitals. The challenges of recruitment are that we need people to work. Everybody needs people to work, and the world is kind of everybody's oyster. So I put 2 job offers out and I lost both of the people because we are landlocked to AAMC Northeast, which is our benchmark to pay, and it's very different than AAMC, say in the Midwest or in the mountain region, where the cost of living is even lower. So that everybody's coming out of medical school with that and residency with that balance, and trying to find somebody who is willing to step into an otherwise busy clinical practice that may not be compensating as well as a practice in another part of the country is also a challenge in recruitment. So with that, those are the things that keep me awake at night. I will defer to anybody else who runs a division who's on this call to comment and add their thoughts before we turn it over to Michelle to talk about what it's like to be actually looking for a job. And Michelle, I remember inviting you to New Haven and hanging out, so I'm glad to hear you're at least on the East Coast. So maybe Eileen first.
Sure, happy to comment. Sorry, I missed the beginning. I was in transit to Texas, if you can't tell by the thing on the hotel wall behind me. But anyway, great to see you all. I think this is a very important topic. I think it's important whether you're trying to recruit or you're looking for a job. And I think this is a really challenging time. So I think take anything that is said today with a little bit of flexibility, because As Kim alluded to, our healthcare systems are under considerable pressure. Our universities are under considerable pressure. And I think that the financial situation is only going to get worse. And so what might be true today in your recruitment may not be true tomorrow. I would say that I think, as Kristen alluded to, there's a variety of different models out there. There's anything from counting numbers of hours, as Kim alluded to numbers of shifts, to numbers of weeks. And weeks may be variable in their intensity depending upon what different types of things you're doing in those weeks. To just saying, well, we'll just hire X number of people and divide the work up. I think that most people have gone to some kind of counting model, but it's highly variable. And if you're looking for a job, just know that. And I think from my perspective, when I'm trying to recruit, I try to be as honest as I can with what that looks like. But I give a range because I think you can't set an absolute number, like I'm going to work 2,100 hours or whatever it is, because of all the things that Kim just mentioned. Like life happens, right? People go on maternity leave, people go on, get injured, people change jobs, and the work still has to get done. The fire department still has to run, even while you're trying to backfill things. So I think there has to be some flexibility, and it's important not to get wedded to a specific number, but rather a range of what's expected of you is probably more realistic. But whatever model it is, try to understand it, make sure they're clear with you as to what it is, so you have a sense of what you're doing. I think the pressures for those of us who like doing academic work are going to continue to be more challenging too, because research funding is going to be more limited. And that's really what most people use to offset their FTE, to be able to do academic time over, beyond the startup period. So in a startup package, you might get some protected time for research if you're a very promising young researcher for 3 to 5 years. But after that, you're kind of expected to have funding. And if you don't have funding, you're going to go back to working full time clinically. And that's just like the reality. So I think that's the other thing to just kind of keep in mind when you're looking for a job. And certainly when I'm recruiting, I have to be really clear with people that, if we're investing in you as an academic person, we are investing, but we're only investing for 3 to 5 years usually. And then, can't offset that if you have to work more clinically. I don't know if I answered any of the questions, but those are my thoughts.
I just add to what was already said. I think in really understanding the model that you're signing up for, really have a clear understanding of what you're covering. So if you are, in-house for trauma, are you also covering emergency general surgery as well as the ICU? Or is your emergency general surgery service separate from your trauma service? And then are you taking home call? And what does that look like and how often? If you are part of a backup call system and you get activated to come in, is that additional compensation or is that part of your package? Is that part of sort of the expectation? How many backup calls are you taking? Are you taking 5 to 6 in-house trauma calls with emergency general surgery, and you're also then taking 6 backup calls? What does that look like if you are getting called in on all your backup time? I think Dr. Davis was saying the importance of redundancy. I can't even stress that enough, that you don't really think about that until it happens. When you think you have 6 people to get your you're working with 6 to 7 people to cover your service, and someone goes out who is unexpectedly ill, and now everyone's stepping up to cover. But what does that look like as far as your time and the compensation for that? So I think it's important to have clarity on all of those different scenarios, particularly if you're covering more than one service line.
I can make a couple of comments as well. I definitely don't have any answers, so it's great to hear that everyone's contributions. And I think even though if you've seen one ACS model, you've seen one ACS model, the challenges are pretty similar. Everything that's been said resonates, and I certainly can identify with all of them. I will just say that I feel like as a division chief, I've had to be a little scrappy in trying to get funds and to sort of make lemonade out of lemons. So we actually have 2 people in house every night, and the reason that we were able to get that is we started with a couple nights, not the entire week, and it was during COVID. And we agreed to do procedures in the COVID units when we were on call. And so that provided some value add. And I think that certainly we're getting more into the surgical rescue realm of, and Laura Moore is on, but she's been spearheading an effort to help OB/GYN with the Acute spectrum patients and using Roboa and sort of translating all of the resuscitation strategies that we use to decreasing blood loss for hemorrhagic shock in those patients, and certainly trying to make ourselves sort of available for other emergencies other than just trauma, even though we're pretty busy with trauma. And so trying to find other ways to provide value. So, and then sort of building other avenues like ab wall reconstruction, et cetera, in some of our complex ab wall patients. So I think kind of identifying opportunities where you can show value to the hospital. We've also gone through a big exercise in trying to get funding for research efforts and sort of demonstrating all the downstream contributions we make in terms of, providing the substrate for orthopedics and neurosurgery, which do a lot of procedures. So, but I think this is a great topic.
Thank you all for the perspective, and excited to hear a little more discussion in the Q&A portion. But we're going to transition next to Michelle Fiorentino to hear her thoughts as well, as a recent recruit and what that experience was like, and just sharing your perspective.
Hi, everyone. So I'm Michelle Fiorentino. I am a first-year attending at Christiana, so I was kind of going through this process about a little over a year ago now. And I think it's like everyone says, if you've seen one ACS model, you've seen one ACS model. And, from a faraway view, they're all very similar. But looking for a job was kind of getting into the nitty gritty of how different how different systems and how different places did it. For me coming out of fellowship, I really wanted to make sure I was somewhere that was doing all pillars ACS, where I was going to get to do trauma, get to do EGS, which was important to me, and also critical care, and seeing how that different split was amongst the different places I was looking, and how kind of I would be utilized. The other big thing was what the hour expectation or what the shift expectation would be, because coming in, I was going to be a 1 FTE, and I want to be clinically busy. I wanted to get a lot of good clinical experience, get in the trauma, get in the operating room, but also I just finished fellowship and residency, and I didn't want to be a resident anymore and be working 28 days a month. So that was kind of one of the things that I found very helpful when talking to different programs, in terms of like asking to see their call schedule, which everyone was very open with me, and taking a look at what the actual schedule would be like, and what I could expect coming in, because I think having the correct expectations walking into a job makes you much happier when you arrive somewhere. So that was kind of the big thing, was just looking at what was going to be expected of me in terms of the call shifts per month, and how kind of things were done differently depending on where you were. I did find a lot of different places did it very differently in terms of, where you just split up the work without any designated plan. I found those a lot less appealing because things happen, because people go out, people quit, people are on maternity leave, people are injured. But how did the compensation change, or how would it be accounted for if that were to happen? If 5 of us were doing the work of 10 people, what would change for me? And I think that's a very hard thing from a division leadership perspective, but it's something that was important for me to know going into the job prospects. And then the other thing that I found very interesting that was happening as more and more hospitals are becoming hospital systems, how many hospitals are we expected to cover, and how many places am I going to be? And is there a chance, I'm supposed to go work at the main hospital? Am I going to be sent somewhere 45 minutes away where, I'm taking level 2 call versus level 1, and how that was kind of expected. And a lot of jobs were very open about that, but also a lot of jobs coming in as a new faculty member kind of expected you to do a week or two, every couple months, or spend some time at another hospital within their system, which I think is just becoming more and more common, especially talking to some of my like co-fellows and other people. That was something that they definitely experienced also. I'm trying to think other things just about staffing issues that I tried to figure out. And then the other thing was, like, if you were working extra, like, how does compensation work if you're in an hour-based or model? Where I ended up at Christiana, we're in an hour-based model now. So we are technically 37 hours a week, which comes up to like $19.50 a year. And it's very much hours based. We count our hours, and if you don't work enough hours, you would have to, pay back, I guess. But if you do extra hours, you would get paid extra per hour, which was appealing. But, also, again, you don't want to work a million hours. You want to make sure you're still have your free time and have that work-life balance. So it is, definitely a variety of different things. But those were the things that were important to me. And I found that the easiest way was talking to the people as I interviewed, and really looking at the call schedule and trying to figure out what would my actual responsibilities be while I was there, and what would I be doing, each day, and how many calls a month, and how many shifts a month or hours a month, and how that would kind of look. That's kind of my basic overview of the recruitee. If anyone has any questions.
Thank you so much, Michelle, for that perspective. And I think that's a great time to really open it up to questions from the group, whether you're troubleshooting yourself and figuring out in our current climate how to make adjustments versus other questions on the topic. Would love to open it to the floor. I can start off one, or Laura, if you have one in mind as well, we can start off as well with questions. I would say the first one that I'm thinking about, this would be to maybe some of the senior individuals that are on the call, or those that are leading ACS divisions, in terms of the current climate and adjusting the current model you may be in. Have there been any items that have come up thus far in terms of making changes to your established model currently? I know one big aspect, at least in discussion for us, is funding for research has definitely been brought up by Kristen Stoudemire, and as well as something we've discussed at our division as well. Has that changed anyone's current state or model as of yet?
So I think that's a really good point, because you have to realize that you work in an institution. And most institutions that rely heavily on indirects from NIH dollars rely on indirect rates of 50 to 70% from NIH. So 50% of the money that the NIH gives most institutions goes to keeping the lights on and letting the Bunsen burners work and funding all of the non-funded mandates associated with research. with the expectation that the Trump administration is going to decrease that level of indirect support, and the number that is floating around is down to 15%. Most institutions are looking at losing 500 million, if not more, money. And that's 500 million that just goes away in one day. So I think the biggest concerns are not only what's going to happen with scientific discovery and the individuals who have been working at these institutions for years doing research, and all of a sudden we can't afford to keep them because they're going to cut the little people, right? The research assistants and the non-ladder track faculty in the research department, but it is going to annihilate the clinical departments, because the only way that a medical student is going to be, a medical school is going to be able to make money is off the backs of the clinicians. So I think that things are going to get worse before they get better with regard to expectations of work hours. It is nice to have a contractual relationship or a document that says you can and will only work this amount, but the bottom line is at some point the patients need to be taken care of. So I will defer to everybody else who's on the call to comment, but I think Lillian alluded to this, and I think Eileen said it point blank. Things are likely to get significantly worse before they get better. So those of us who are hoping to up staff to mitigate a work environment that may be challenging, particularly if people are out, may not be able to do that, and people may be working harder than they anticipated working. The flip side of that, as I was talking to a young lady who I've recruited as a 50% researcher with a nice startup package, and she's telling me about friends of hers who are fellows looking for jobs who thought they had jobs, and the jobs have disappeared because there are hiring freezes. So I think we live in interesting times, which is kind of an old Chinese curse. It'll be interesting to see what happens for the next couple of years, but I'm going to turn it over to somebody who knows more than I do about it.
Was just
Yes, Rosemary.
yeah, I was just gonna throw something in there, kind of the almost opposite of what we've been talking about. I'll just use myself as an example. I'm, varies. I'm about 70% funded now. So my funds are going to go away. Let's say all of them. So, okay, so you could say, okay, I work harder. But say, what if 25% of my, and it's not, but so it goes away for all these people, but there's a set amount of work. And so, yes, you could say I could work hard, but there's only so much work for everybody to do. And so if we're losing all this financial money from the grants going away, our institutions, our departments, whatever, are going to really be suffering financially. We can't make up for that. I mean, you can't. I mean, yeah, you could go try to do more surgeries and stuff. You know what I mean? But it's kind of an interesting problem because this is what we got to work with.
I particularly worried about that. I think if you think about our internal medicine colleagues in academia, I mean, we have pulmonologists that are so heavily on the research side that they work maybe 2 weeks a year, right? And if you have 40 of those people, and now they don't have any research funding, but you don't have, that much work for them to do clinically, they're going to be layoffs. I mean, even among academic faculty, I think we're a little more protected because our groups tend to be smaller and we are firefighters and the work needs to get done. But I don't think we should kid ourselves that we're not going to be in a very good negotiating position with our universities when they're laying off large numbers of staff and ultimately faculty over this. And I think it's not just, I mean, I hate to sound like the Debbie Downer here, but I'm pretty Debbie Downer this week. It's not just the research indirects, it's the Medicaid funding. And our institution, they're like, oh, well, with the research indirects, we'll lose $90 million, but if they cut Medicaid, we'll lose $400 million. I mean, these are numbers that we can't compensate for, and the state can't compensate for. So, I don't know what's going to happen. but something's going to get cut in Medicaid somehow, and the indirects are a great risk. So I think we're sort of being attacked on two fronts, both the clinical income side as well as the research income side. And so I don't know what that means for those looking for jobs, except take what you can get right now. Maybe. I don't know. I'm worried.
I mean, maybe I'll add, like, I agree with everything, but maybe I can add maybe a little bit of lightness. Here's a little bit of lightness. The indirects are being cut, not necessarily the grant dollars. The NIH has $48 billion, and the majority of that's for external funding. That money is still going to be spent. It's just different with how it's going to flow through organizations. Now, Congress funds each of the different institutes separately, which I just learned recently. I didn't know that. So the NCI has direct funding from Congress. If the administration wanted to cut funding and decrease the NCI's budget size, it would have to go through Congress. So there's some friction there that limits that. That's not a complete buffer, but it's at least one piece of maybe positive news in all of this. But because the indirects are being cut, I think, and as Eileen said, the clinical dollars are being limited. And in California, for all those of you who are in California, if you're at what's called an expensive hospital, like the hospital behind me there, then we're now capped on how much we can charge commercial payers as well. And that's actually that turns out to be our biggest financial hit. But I think what we're going to see is in surgery in general, is that the appetite for having surgeons do research across the organization is going to be less. The surgeons pulling in indirects feeds an excitement about surgeons doing research. Surgeons having more of that money go towards them doing their research, but less going to the general pool, still makes us look really expensive and not pulling in as much indirects. So I think the downwards pressures on research are going to be greater for surgeons because we have a different income. And so to cover costs for us is very different than for an internist. So I think it's going to be the distortions and the changes are going to be are going to be really hard to predict because of all those different forces. But maybe just to add one piece of light in the fact that there still are $48 billion that the NIH has to spend somewhere. It'll still be entering the economy. And whether that helps us, who knows, but it will be entering the economy.
It may depend on what kind of research you want to do also. Like, so, some contracts are not being renewed because of the type of research that they are in health equity or injury prevention, violence prevention. The CDC got decimated today. So we'll see. You're right, that money's still there, Kristen, but what it'll be spent on, I don't know.
It strikes me that this group started during COVID, and at that time, it didn't seem like there was a light at the end of the tunnel, and we were talking about all the changes to our world and how we didn't have the answers, and somehow we all got through it. And so I feel like the benefit and importance of a group like this is, again, sort of obvious in the sense that we can all kind of share our concerns with each other and hopefully band together to try to figure out how we're going to get through.
Extremely well said. Thank you, Lillian, and thank you everyone for the input. Other questions that the group has that we can pose to our panelists and other mentors online.
An unusually quiet group today.
A somber topic.
Can be in some ways. I know my mind immediately jumped in hearing some of the conversations that, if there is a shift in our structure and a shift in what our focus is, then do our aims and endpoints of promotion as well sort of shift too? Because a lot of it is based on, research and academic productivity. And, I think there's a big component of our clinical productivity and clinical education too that's incorporated. But my mind did jump there for a moment as well, thinking of that target that could be changing as well.
Yeah, I don't think it's all gloom and doom, but I do think that things are going to look very different um,
Mhm.
in the next 3 to 4 years. They'll probably look very different in the next 2 years. I know that a lot of organizations who created we call them the academic clinician, but basically the individuals that do teaching and they do surgery and they take care of patients. And there is absolutely no expectation um, for academic productivity. And I'm at Yale, right? I mean, we're supposed to be an academic organization, but a focus on transitioning from the academic mission to the care of the patient, and promotion will be based on regional and national clinical reputations, and becoming a center of excellence, or a a high volume draw. So there are ways to think about at least the promotion question, but I do think that academic surgery is going to look very different in the future than it looks now. I mean, surgery in general looks very different now than it did in the COVID era. I mean, we're all on Zoom. We can have webinars like this and participate and interact together, and we're at the far-flung reaches of the country. So, COVID did bring some good things forward. COVID also brought some bad things forward. Financial pressures on the hospital, for one. But we are going to see layoffs. We may see discussions around salary cuts for some of the more lucratively compensated physicians, particularly if their effort is not 100% clinical FTE. I do agree with Dr. Bulger that if you're lucky to be offered a job, I would take it, because I don't know how many of those job offers are going to exist in the next 12 months. But we'll see, right? We're really kind of in uncharted territory.
I agree. I would be less worried about promotion because the universities adapt, and they've already kind of adapted in this direction, right? As Kim is alluding to, there are tracks for clinician educators, and we all fit that. So I would not stress about promotion.
Other questions or comments from the group?
A very quiet group.
I know, it's weird. And I think we have one of our biggest turnouts today. No,
Maybe
I
we're
think,
being depressing.
Maybe I'll ask a question of the group.
yeah.
Has anyone's institution been talking to them from a high level about what they can expect? So, for example, we had our CFO from the healthcare side and our dean of research on the School of Medicine side talking to us about expectations. And not too surprisingly, our research person said, keep chugging ahead, keep submitting grants. Don't stop submitting grants. We need that money, and we think we'll get some of it at least. And then on the hospital side, it was, what you were hearing about from Dr. Davis earlier, which is, and Dr. Bulger as well, Medicare cuts, Medicaid cuts in California, OCA cuts, indirect cuts, the world's exploding, but keep on working. And so it's interesting to me that they're reaching out to the front line to get messages across. I'm just curious if that's happening anywhere else.
We have a weekly town hall with the dean and the CEOs of the health system to basically throw out the numbers I'm throwing out of how bad it could be. I think to prep people for that. But the only thing they've instituted is a hiring freeze, a travel ban for using university funds to travel. And you can't buy food to eat at your lunch at your conference and your whatever M&M, which none of those are going to solve the budget problem. So we'll see where it goes.
I mean, yeah, at Morehouse, we are talking about it because our funding is very tenuous given the whole mission of Morehouse. And we have the same bans that Eileen just talked about in terms of travel only if you are presenting, and yeah, there's a huge ban on food, which at Morehouse we love to feed people because that's how we show love. So that's been really tough. But nobody can actually quantify it because nobody actually knows what it is.
Yeah, we are actually still allowed to travel, which is nice, but they have impacted food budgets, and they just laid off an entire swath of management at the hospital. They fired 600 people, all at the executive director level, and told them that they could all reapply for the 110 jobs that are being refurbished.
Wow.
So we are having mass layoffs.
Yeah, we have a hiring freeze and some limitation on travel, but that's the biggest thing so far for us. Other stuff is coming though. I think we all feel it.
I think even more reason for us to be very cognizant that we're not alone, especially within the specialty, which is very, very team-based specialty, and we all really work together and we share thoughts and ideas, that we make sure that we take care of us and our patients, especially while this is happening. I think the forces, as we all been discussing, I think will come down hard on us because we already are experiencing a lot of the weight of overcapacity hospitals and expectations to do more with less. I think that has been our characteristic before all of this financial turbulence started to hit us. So I think it means that we really have to be deliberate and thoughtful and work together as a group to make sure that we specify how these patients continue to get care and in the way that we've now elevated it to.
I actually think it's a huge opportunity to determine how we deliver care and what do we do that actually adds value and what do we do that doesn't add value. I mean, I don't know how things are at your institution, but if somebody desaturates in the middle of the night, they get a CTA of the chest and the yield on that is 0, maybe 1%. So, trying to refine clinical protocols and put thoughtful triggers in our beloved EMRs to say, do you really need this test? Does the patient meet this criteria and this criteria and this criteria? I actually think it's an opportunity as we look to add value and cut costs to improve quality. But I think that some of that may come along. There's something in the chat from Lindsay. She's got a poor internet connection, but I think she has a question.
It looks like Lindsay has said that she has poor internet connection, but works at an institution that doesn't have a set number of weeks per year, but would like to move that direction. How do you or don't you incorporate clinic days or elective surgery into those counts?
So the institutions that are hardcore shift-based will count everything, including clinic days. People who are somewhere in between really make it focus more on weeks or inpatient days or hours. So again, it's all an evolution, and you probably would do well to talk to different institutions who are doing a shift or hourly model to see how they manage it. But the ones that are the strictest at it do count every drop of time, inpatient or outpatient. The real hard part is how you quantify the other stuff you're doing. That's the real challenge. It makes it easy if the hospital is giving you a 0.25 or a 0.50 FTE, but those are going to start vanishing as well. I think, at least at our institution, they put a hold on the development of any new directorships.
This is Drea Long from Fresno. Has anyone successfully, we're in a weird trifecta because we're separate from UCSF, separate from the hospital, have a multi-specialty medical group. So it's always a little complex, but successfully navigated trying to get hospitals to compensate better for the work that we provide as ACS surgeons for the things mentioned, being there in the middle of the night, doing those things. Are there any real world success stories of departments?
I think anytime you get somebody to pay a salary, add a set number of shifts without wondering what's coming in the door, i.e. acknowledging the fact that acute care surgery is like the firemen and the police, and sometimes we're not going to work, but most of the time we are, and we're going to be there to rescue. That counts as a success. They are paying surgeons salaries. They're not paying internal medicine salaries. They're paying surgeon salaries. So I view that as a success. And if your chief can negotiate that, it's a great win. Because surgeon salaries are significantly higher than most healthcare providers, even other proceduralists, except for maybe cardiologists.
There's a question in the chat from Stephanie Bonney, sort of in a similar idea of determining value or how to express that. Is when you're negotiating an administrative role, how do you demonstrate that your time as an administrator is worth more than a pediatrician's? If you weren't administrating, you would be in the operating room and gaining those RVUs.
Yeah, I think we're going to hear those discussions. I think you're right, Stephanie. There's going to be, as everyone's counting all of their pennies, they're going to be saying we can't afford to have a surgeon in this spot. The one thing we do have is that when you don't involve surgeons in decision making, that could potentially compromise the largest sources of income for your healthcare system, because most of the money does come through the interventional platforms. And so they have to engage surgeons and proceduralists. So there's going to be some balance there, but I think that will be entering discussions for areas where there might be seen as equivalency for the physician input.
Yeah, thanks for answering that, Kristen. I think we're dealing with that right now where it's like, well, if I could hire a cheaper physician to do your job, but like a pediatrician can't run a trauma center. So, how do you demonstrate the value of the experience of a surgeon, even if it's not necessarily being in the operating room, it's just being exposed to the things that surgeons do. And that's going to be a challenging, I think that may be our sort of next frontier is like, what do we do about that?
Yeah, I think you have a little bit of leverage if you are, they value their level 1 trauma center status, right? They don't want to lose that, so therefore they're going to fund a trauma director as a surgeon because it's kind of a requirement, right? And so I think you have a little bit of leverage there in saying, you're not going to have a trauma center if you don't have somebody in that role. Some of the other roles, it may be a little bit harder. But if you're having problems with your operating room efficiency or issues with other surgeons in the operating room, sometimes a surgeon can wrangle that better than a pediatrician. So, I think part of it is sort of identifying what problems you can solve, what leverage you might have to solve a problem that will help the hospital. And then they'll see you as a valuable person to have in that role, if that makes sense.
Well, and I agree with you. And I think that that's where we really need to leverage our position as like we touch every piece of the hospital, right? Like we are familiar with the emergency room. We are familiar with the operating room. We are familiar with the floors, the ICU. Like there's not a part of the hospital that the trauma surgeons haven't been in except like maybe the NICU, and so saying like we are very fluid in all of these spaces and we understand the operational issues in all of them really gives us, I think, a lot of leverage to hospital administrators. I'm asking a lot of these questions sort of just to hear the discussion. I mean, I've been having these discussions with my administrative leaders and they fortunately kind of get it, but there's a few spaces where it's like, I just need to kind of get them to come along a little bit. Like they don't really understand what surgical rescue means. And I'm like, look, we're there in the middle of the night giving an airway to the guy in the NICU that has angioedema or, like you have to really use those individual examples and have those discussions in very granular detail in order to really bring the entire group along, that like this is what value our group is providing to the hospital system, and what value I'm providing.
I think that brings us to the hour. It's been incredibly rich discussion. I know some depressing aspects, but uplifting as well. So a combination, and I think I really enjoyed how Lillian described it, that very much having this platform to be able to talk to one another about it, connect and support each other, problem solve is extremely incredible and a wonderful aspect of WITS, and glad that we can connect this way. Upcoming, we will have a webinar. Laura, you'll have to remind me. I believe in July we have our mentoring town hall, and then in October we'll have a webinar looking at sort of mid-career, determining, whether to stay in your current position or look towards other opportunities. So that'll be interesting as well. And of course, the happy hour and cocktail hour during our AST reception, which will be nice to connect in person. So thank you everyone for joining, and have a good rest of your evening.
And also thank you so much, everybody, for a fantastic conversation. Really appreciate you.